Okay, good afternoon. Dr. Lenny, thank you very much for paving the way for the subsequent lectures. These are very important concepts for us to understand its applications. Now, I'll be doing something I have not done before in any lectures. Now, I want to take the photo of my audience. This is a full pack room, and I'm very glad that you're all here. This means that there is already a growing interest as far as CPET is concerned. If you won't mind, I just need a few seconds. Okay, thank you very much for that time. Okay, this was actually well explained by Dr. Lenny. Please do not get overwhelmed, okay? In this part of the lecture, we will try to simplify some of the concepts. Some of my slides were also courtesy of Dr. Bernice, and I'll be repeating some of the slides that were earlier shown by Dr. Lenny. It was emphasized earlier that when we say CPET, okay, this means trying to get a report on the integrative and comprehensive response of the body in terms of the effects of its effects on cardiac, respiratory, and muscular system. And this was already shown earlier. Even at rest, we have oxygen consumption. So when you inhale, oxygen flows in. It is distributed in the body by the cardiovascular system. It goes to the muscles. And then from the muscle, it goes back to the heart. And then carbon dioxide is exhaled. Now, this is true during rest. And when you are active, when you do your exercise, you increase the oxygen consumption. So you increase the carbon dioxide that is produced by the muscle. This is expelled by the respiratory system. And when you inhale, you increase your effort, so you increase your VO2 and VCO2. CPET has a wide spectrum of clinical applications. It's really an objective determination of functional capacity. There are resting parameters that we use for our patients that cannot answer some of our questions. So another way of doing it is by doing CPET. So what you want to do in CPET is to evaluate the clinical response of the heart, the lungs, and the muscles under increased physical stress. Well, this was shown already earlier. There is some difference whether you use the cycle ergometer or the treadmill. There was one of our fellows that asked the same question. What I told her was, kung ano yung available sa inyong center. Okay? Cycle is cheaper than the treadmill. So if the budget would just dictate you to having just the cycle ergometer, that's well and good. But there are some differences within the results of these two. Okay, let's go now to the indications of exercise testing. This was already shown earlier that you want to determine the peak VO2. You want to evaluate autoproportional exertional dyspnea. We use this often in pulmonary rehabilitation programs. For this particular afternoon, we would like to use or see the applications of CPET in two important things. One is preoperative evaluation, and the other one is determination of disability. Is CPET safe? Yes, it is. And the data would show that in terms of complications requiring hospitalization, it's less than 2 per 1,000. In terms of major cardiac event, it's it's around 1.2 per 10,000, and mortality is 2 to 5 per 100,000. In our center, we never had any morbidity or mortality. God willing, we don't want to see any morbidity or mortality in our CPET. Okay, shown earlier, okay, these are the standard equipment. So you have the blood pressure, the mass, ECG, gas analyzer. And it was explained earlier that as you do your exercise testing, what we use is a breath-by-breath system. Ibig sabihin yan, while the patient is doing the exercise, each breath is determined by the machine. And this is shown by the dots that that are shown here in this particular picture. Okay, I would show to you a picture for data privacy. We'll call him patient A. Patient A as in Abner, okay? Okay, the 9-panel shot was shown. So we determine oxygen consumption, rate of carbon dioxide production, minute ventilation, BP monitoring, and O2 saturation. I would just like to show you the difference of how we do CPET now and before. So this is how it is done now. You have a face mask connected to the machine. Years and years ago, this was how it was done. Okay? We use a mouthpiece to determine the same parameters, but it was quite difficult to do this. You have a mouthpiece, and then the problem was salivation during the testing. So that's the difference, although we now have a better software and a better machine. Is VO2 peak and VO2 max the same? They are actually different. But in healthy individuals, they can be used interchangeably. When we say VO2 peak, okay, this means that this is the patient's best effort. When you say VO2 max, this is the intensity at which the actual oxygen uptake reaches the maximum, beyond which there is no increase in effort can further raise it. Reading a VO2 max test result would really be like a pulmonary function test. You have a prescribed predicted normal, then you ask a patient to do the exercise, and then you compare what that patient can do over what is expected for that age, gender, weight, height, and race. So, best effort for VO2 peak, and with plateau, the maximum that can be achieved with VO2 max. Okay, the other very important concept that was explained earlier was the anaerobic threshold. It can be reported as liters per minute or ml per kilo per minute. This was already shown earlier. This just further emphasized that when you reach the level of transition from aerobic to anaerobic metabolism, you have lactic acid accumulation, which will cause a steep rise in your VCO2. That point by which you start seeing this steep rise is the anaerobic threshold, and this will be a very important component in the determination of preoperative evaluation of our patients. Same thing you see in dots, this one presented in graphics. So both oxygen consumption and VCO2 runs linearly until a certain point where you have lactic acidosis and you will have increase of carbon dioxide output. Are the results normal or abnormal? Many parameters were discussed earlier, but for this lecture, we will only emphasize on two. That's VO2 max or peak and anaerobic threshold. When the VO2 max is 84% or higher, it means you're normal. You have good exercise capacity. Anaerobic threshold should be greater than 40% of the maximum oxygen consumption. It happens in between. It's in between 40 to 80%. And what happens when you have certain diseases? You can see here that VO2 or VO2 max will decrease in heart failure, COPD, ILD, and obesity. And likewise, you can see the decreased values in anaerobic threshold. It decreases in heart failure, maybe normal at decrease in COPD, decrease in ILD, and decrease in pulmonary vascular diseases. Okay, this is the report that was shown earlier. You have three parts: the tabular data report, the Wasserman 9 panel, and the interpretation. So do not get overwhelmed, because this will have very important information on what you will do with your patient after the test. When we do preoperative evaluation, this is mainly based on medical history and comprehensive physical examination. We utilize chest x-rays, laboratory exams, and occasionally we do exercise testing in evaluating the risk for postoperative respiratory complications of our patients. What are the risks involved if you are 65 years and above? So these are the patients who were, I heard yesterday, called chronologically gifted. In other words, these are the elderlies. Then also presence of comorbidities. Male gender pose a higher risk for surgery, surgical procedure, emergency surgeries. Admission of patients during the weekend. I think this is also true in our setting. When patients are admitted in the weekend, less number of consultants seen, and probably increase some of our complications. And the risk is higher on patients undergoing cardiothoracic surgical procedures. What are the expected numbers when it comes to perioperative morbidity and mortality? The incidence can be anywhere from 3.1 to 9%, depending on what center you're working. We want it lower, the better. And these are the potential complications that can occur in our patients when they undergo surgery. Atelectasis, infection, prolonged mechanical ventilation, respiratory failure, exacerbations of their pre-existing disease. Now, what does preoperative evaluation do? We want to separate those patients who will be able to tolerate the surgery as against those who will not be able to become, or who would not be good surgical candidates. So that's the main reason for preoperative evaluation. And then we do what is essential and necessary. This is a relatively old document published in 2003 by the American Thoracic Society. These are the cardiopulmonary indications, evaluation of exercise tolerance down to evaluation of cardiovascular patients, rehabilitation, preoperative evaluation, evaluation of impairment disability. But specific clinical applications will include preoperative evaluation on patients undergoing lung resection surgery, elderly patients who are undergoing major abdominal surgery, and lung volume reduction surgery for patients with emphysema. Should all patients with pulmonary problems undergo CPET? Yes or no? Okay, the answer is no. And we will explain to you the criteria. The most benefit would come in patients who would be the borderline patients who would otherwise will be excluded from undergoing surgical procedures. Okay? So there is a specific population, patient population, that are recommended to undergo CPET. Okay. Now this is from the ACCP 2013 Evidence-Based Clinical Practice Guideline. Okay. They use PFT as part of the pre-op evaluation. If the predicted FEV1 and predicted DLCO is 60% or more, that patient will not have to undergo CPET because he is a good risk, though that patient is classified as low risk. But if the patient is lower or the patient has lower numbers, that patient may have to undergo CPET. If the oxygen consumption is greater than 20 ml per kilo per minute or 75% of the VO2 max, that patient is low risk. So that patient, you are confident that this patient will be able to tolerate the surgery. If the result of the VO2 max is around 10 to 20 ml per kilo per minute or about 35 to 75% of VO2 max, that patient is a moderate risk. If the number of VO2 max would show will be less than 10 ml per kilo per minute, that patient is high risk. Recommendation, probably you would not want to operate on these patients because for sure you will have major complications. Okay, the values of the cut-off thresholds may vary depending on age. So let me just enlarge that. The VO2 peak measured in ml per kilo per minute using a cycle ergometer will vary on different ages. The higher values will be seen on younger patients. So it can be different, the average value may be different between males and females. So age 20 to 29, the good value will be about 42 until you reach the age of about 60 to 69. The value that is acceptable or that is on average is around in the 20s, 22 up to 21. Now, how does this relate to predicting pulmonary problems after. If the value of your oxygen consumption is less than 15 ml per kilo per minute, that patient has an increased risk. But if the value is less than 10 ml per kilo per minute, the risk is very high. Okay, how about the anaerobic threshold? Anaerobic threshold, we said earlier, should be around 15 to 25 ml per kilo per minute. The normal occurrence will be at around 40 to 60 or 80% of the maximum oxygen consumption. So if the value of the anaerobic threshold is less than 9 or 10, this warns you that this patient is a high-risk patient. So watch out, surgery might not be a wise decision for this particular group. Let's look again at 80 anaerobic threshold as a component of preoperative evaluation. Now, the value can be different. An 80 of at least 11 ml per kilo per minute is required to safely undertake surgery. If the surgery would involve hepatic transplantation, it was shown that the peak VO2 of less than 60 and 80 of less than 50% predicted is associated with 100-day mortality. So the value now is higher than the usual surgery. And if the patient is to undergo an abdominal aortic aneurysm, peak VO2 of 20 ml per kilo per minute, low anaerobic threshold, okay, will be associated with significant postoperative complication and significant 30-day mortality. So hindi specific, no, but more complicated operations would have higher values of cutoff threshold. Okay. This is another article about AT as a preoperative risk stratification. Patients is involved 187 elderly patients divided into two groups. Those with less than 11 ml per kilo and those with greater than 11. You can see here that the percent of mortality is much higher if the patient has an anaerobic threshold at levels less than 11 ml per kilo per minute. I would just like to cite some of the documents that has used CPET as a preoperative test. This one is for lung resection. It might not be very visible at the back, but the bottom line will be numbers if less than 10 ml per kilo, or rather, okay, numbers less than 10 ml per kilo per minute is associated with high risk. Okay. And in the other guideline, if the numbers are okay, you can proceed with pneumonectomy or lobectomy. But if the number is less than, the VO2 max is less than 10 ml, the patient becomes a high risk for procedures. Now, this is a more recent document published in 2018, and these are the recommended indications for CPET. It's recommended to estimate the likelihood of perioperative morbidity and mortality, and this can contribute to the perioperative risk. This is grade B evidence. It can be used for clinical decisions about the most appropriate level of perioperative care, also grade B evidence. It can identify previously unsuspected pathology, grade B, and it can be a guide for pre-rehabilitation and rehabilitation programs, grade B. I would like to pose again the contraindications. Not all the patients that you will refer for CPET will have to undergo CPET, because if the patient will have any of these absolute contraindications or relative contraindications, you might have some second thoughts in subjecting this patient to this type of examination. Okay, we have again our model, patient A, as in Abner. Okay, this just goes to show, okay, that as you exercise, you increase your oxygen consumption. And VO2 max is associated with postoperative morbidity and mortality in majority of clinical cohorts, depending on the number that this guideline utilize. Again, the same numbers for AT, anaerobic threshold provides an index of submaximal sustainable exercise. Actually, in some cases, the AT might not appear. If it does not appear, there might be problems. And this is usually occurring in patients who are very weak, okay? And therefore, without the AT, assuming that it was done on a maximal level, that patient becomes another high-risk patient. Okay, when you do a preoperative evaluation, okay, you determine first the reason why this patient would have to undergo the testing. You review the history, you review the other information, okay? I'll just hurry it up because I have only a few more minutes. Okay, preoperative evaluation. This is from Greece, from the Hellenic Thoracic Society. And these are similar to what I've shown you earlier, okay? Numbers of 10 ml or less than 10 ml states that these patients are at high risk. And the Hellenic criteria for determining risk is actually much simpler. If the FEV1 predicted is 40% higher, the LSO is 40% higher, that patient is a good risk, no CPET. But if the numbers are lower, okay, that patient may be a high-risk patient. Okay, I just want to show you the differences of cut-off values by different international societies. CPET will be indicated when the FEV1 and DLCO is less than 30% predicted. Same with, or rather for the ERS, FEV1 or DLCO of less than 80%. So mas mataas ang cut-off value. For the British Thoracic Society, it's actually around 40% or less. In terms of cut-off values, para sabihing low risk, 20 ml is the cut-off value for ACCP and ERS, and 15 ml per kilo for BTS. I would just like to go through the high risk, okay? High risk. For ACCP, VO2 max of less than 10 ml per kilo or 35% predicted would qualify your patient to be high risk. Same with the ERS, and the value is actually slightly higher than in the BTS guidelines. Okay. So we have a local data. Very briefly, I'd just like to show to you the data of Palma, one of our fellows who graduated before. And they utilized anaerobic threshold. Now, to be very brief, the numbers that came out in this study were as follows. Morbidity or complications can appear if the AT is lower than 10.5 ml per kilo, and the VO2 peak showed a number of 14.7. If it's lower than this, that patient will have a higher risk of complications. So it's very similar to the other international guidelines that we showed earlier. Okay, I will go fast on the disability, okay? Disability is very important because the patients are expected to be paid for certain disabilities. And CPET can be an important tool or parameter, okay? Now this one is a guideline, okay? This is from the South African Thoracic Society. I would no longer go to the definitions of disability and impairment. So, just a reminder, when you say impairment, impairment is a medical concept, while disability is a legal concept, okay? And it is clear that even if you have impairment, that does not necessarily mean you have disability. Now, these are the numbers that was used by the South African Thoracic Society. It is case 1 up to case 4. Case 1, no impairment, or class 4 rather, there is severe impairment. And as far as the CPET is concerned, if your number is VO2 max is 25 ml per kilo per minute, that means you don't have any disability or you don't have impairment. But if your number is less than 15, okay, that means severe impairment. So these are very objective numbers that can help physicians decide. Now, this is how they go through the evaluation of disability. It's not only the physician. So there's job data, patient data, and then clinical data, and then this is assessed by someone who is responsible. Now, I was trying to look for some sites on where CPET is used, and I found a number of law offices, okay, so legal law offices in the US, and I'll just give you one example here. CPET and disability, how this testing can help you win disability benefits. Okay, that's the premise. And CPET can be used in a number of other diseases, not only for pulmonary disease, but for their office, it's COPD. Ang aim is objective medical evidence will help you get your disability claim approved more than anything else. Okay. I tried to review the literature that we have, or rather online, on what agencies or companies are responsible for disability determination. I looked online for the GSIS criteria and the SSS criteria. And again, I won't go through anymore with the definition of disability. When you look at the document, actually, for respiratory disease, there were 3 diseases included in the disability determination. That's TB, asthma, and COPD. For COPD, they use the old classification, the gold stage of mild, moderate, severe. The GSIS document also looked at the CAT questionnaire. And for the cardiovascular system, this is where they have some statements as far as exercise testing is concerned, none for pulmonary patients. And the documents, when you submit to GSIS, you are required medical evidence, medical progress reports, which would include your history, your physical examination, and your diagnosis. For SSS, I also tried to look if CPET or exercise testing is included in their evaluation. Okay? What they need is a medical certificate to be accomplished by the attending physician, supporting documents, X-rays, ECG, ultrasound, blood chemistry results, and the medical certificate should be by the attending physician within 6 months from filing of this information. Evaluation, disability evaluation for TB and for COPD. And for COPD, the requirement only would involve chest X-rays and pulmonary function testing. No CPET required. Okay. For the last several minutes, I just had a few minutes of overtime. We have discussed to you some of the clinical applications of CPET. For preoperative, it's already being used now, but for disability determination by GSIS and SSS, it is not yet being used in our setting. So, I would like to thank patient A, as in Abner, for allowing me to use his photo in our lecture. And I hope that we all learned something new today. Thank you very much for your information.